Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
When you hear headache, you probably think, okay, something annoying, maybe a dull ache you can kind of push through.
Right, just power through it.
Exactly. But what if I told you that for millions, literally millions of people, a headache is just the tip of a much deeper neurological storm? We're diving into migraine today. It's a truly debilitating condition that affects something like 11% of the global population. It is so much more than just a headache.
It absolutely is. And today, we're taking a really comprehensive deep dive into understanding migraine. We'll try to unravel its quite intricate biology, look at the revolutionary new ways it's being managed, and also confront its profound societal burden.
Yeah, and our mission here really is to pull out the most important insights from the latest research for you. Give you a shortcut, kind of, to being genuinely well-informed about this condition that's so often misunderstood.
Definitely misunderstood.
We want to cut through the noise, maybe uncover some surprising facts, offer practical takeaways, and really help you grasp what's truly important from, well, all the material out there. So let's start by defining migraine properly because, like you said, it's way more than a simple headache. How do doctors even start diagnosing something this complex, especially given how different it can feel person to person?
Right. Well, the foundation of modern headache medicine, and really its transformation, it rests on this very rigorous, internationally recognized system. It's called the International Classification of Headache Disorders, or ICHD-3.
ICHD-3. Okay.
Yeah. And it's basically a detailed criteria-based approach, kind of algorithmic, you could say, for diagnosing all known headache disorders.
So it's like creating a universal scientific language for headaches. That sounds incredibly important for something with such subjective symptoms.
Precisely. I mean, before ICHD-3, headache classification was notoriously disorganized. A bit of a mess, frankly.
Yeah, I can imagine.
This system totally changed that. It moved headache disorders into one of the most well-classified areas in neurology. And the real insight here is how that standardization turned migraine from this sort of vague, bad headache into a universally understood, researchable neurological disease.
Which means a diagnosis in one place means the same thing somewhere else.
Exactly. A diagnosis of migraine with Aura in New York means the exact same thing in New Delhi. And that's absolutely essential for global research, for consistent patient care, and of course, for developing new treatments.
That's a powerful shift. Okay, so within this unified language, what are the main types of migraine that most people experience?
Well, the most common type, by far, is migraine without aura. Sometimes people call it common migraine. And for a diagnosis, you typically need to have had at least 5 attacks like this. These attacks, they last between 4 to 72 hours if you don't treat them.
That's a long time.
It can be. And the headache itself has specific features, at least 2 of these 4. It's often on one side of the head, feels pulsating or throbbing. The pain is moderate to severe, like bad enough it stops you doing normal activities, and it gets worse with just routine physical movement, like walking.
Okay.
Plus, you also have at least one associated symptom. Usually that's profound nausea, maybe vomiting, or being extremely sensitive to light, which is photophobia, and sound, phonophobia.
Got it. So that covers the common type. But what about when people talk about classic migraine? What does that usually refer to?
That's usually migraine with aura. About a third, maybe 30% of people with migraine experience this type.
Okay.
It's distinguished by these transient, fully reversible neurological symptoms, the aura that typically come before the headache, though sometimes during.
What kind of symptoms are we talking about?
Mostly visual. Seeing shimmering lights, zigzag lines, maybe temporary blind spots. But they can also be sensory, like numbness or pins and needles, or sometimes involve speech difficulties. Rarely, even motor weakness.
And the diagnosis criteria are different.
Yeah, for aura, you need at least 2 attacks like this. The aura symptoms have to build up gradually, usually over 5 minutes or more. Each symptom typically lasts between 5 minutes and an hour. And crucially, the headache usually follows that aura within about 60 minutes.
And then there's a form that sounds, frankly, much more severe, where the headaches just keep coming.
That would be chronic migraine. And yes, it's a severe progression. It's defined by having a headache on 15 or more days per month, for over 3 months.
15 days a month or more. Wow.
Yeah. And on at least 8 of those headache days, the features have to be migraine-like, or the headache has to be relieved by migraine-specific medication. It's a really tough transition. Unfortunately, about 3% of people with episodic migraine progress to chronic migraine each year.
It's really clear from those definitions, isn't it, that a migraine attack isn't just one moment of pain. It's like this whole dynamic process, multi-phase, stretching over hours, maybe even days, which makes the period someone is actually disabled much longer than just the headache part.
Exactly. Think of it like a journey, distinct phases, though they often overlap a bit. It starts with the prodrome, or premonitory phase.
Prodrome, okay.
This can kick in hours, even a day or two, before the actual headache hits. And during this time, you might get these subtle but kind of telling symptoms. Mood swings could be depression, irritability, even euphoria sometimes, difficulty concentrating, fatigue, lots of yawning, maybe increased thirst, neck stiffness, even GI stuff like nausea or food cravings.
I think this is a really crucial shift in thinking for a lot of people, right? It's not about triggers at this point. It's the actual first stage of the attack. The brain is already starting the process.
Precisely. And recognizing this is huge because it gives you this critical window for early acute treatment. Taking medication right then during the prodrome can be way more effective. Sometimes it can even stop the headache phase completely.
That's fascinating. So after the prodrome.
Then, for about that third of migraine auras comes the aura phase. Those transient neurological symptoms we just talked about, usually lasting 5 to 60 minutes. And this phase, the aura, it's directly linked to a specific electrical event happening in the brain.
We'll definitely get into that event. And after the aura, or if you don't have aura, comes the part everyone knows, the headache itself. The attack phase.
Indeed. This is the most recognized, usually the most debilitating phase. Lasts 4 to 72 hours if it's not treated. The pain, as we said, moderate to severe, often throbbing, pulsating, typically one-sided. And a key thing is that it gets worse with routine physical activity. Just bending over, walking upstairs, that can make the pain spike.
Which is why people often just have to lie down in a dark room.
Exactly. And it comes with that profound nausea, sometimes vomiting, and the extreme sensitivity to light, sound, and sometimes even smells. That's osmophobia.
But the misery doesn't necessarily end when the headache finally stops, does it? There's often this recovery period afterwards.
No, it often doesn't. About 80% of patients experience what's called the postdrome. People often call it the migraine hangover.
Hangover, right.
And it can last a day or two after the headache resolves. And for many, it can be just as disabling as the headache itself. The symptoms often kind of mirror the prodrome: severe fatigue, that feeling of brain fog, body aches, neck stiffness, mood changes, maybe some lingering sensitivity to light or sound.
So a 12-hour headache could actually mean 3 days of feeling wiped out and not functioning properly.
Easily, yeah. When you factor in all the phases, it really underscores the full scope of disability, doesn't it? And why just treating the pain isn't the whole picture.
Definitely. Now, beyond these common types and phases, you mentioned there are some rarer, more specialized subtypes. And interestingly, they've given us crucial clues about the underlying biology.
They really have. One example is hemiplegic migraine. It's rare, but severe. It's a form of migraine with aura that includes reversible motor weakness, usually down one side of the body, almost like mimicking a stroke. Yep. And when it runs in families, it's called familial hemiplegic migraine, or FHM. Research into FHM has been absolutely pivotal. It gave us this incredible insight. It's linked specific mutations in single genes that control ion channels, basically, the gates that manage how electrical signals, ions like calcium and sodium, flow in and out of brain cells.
So the amazing insight from these rare, severe cases is that they provided direct genetic proof. Proof that migraine isn't just a symptom, but maybe a fundamental difference in how the brain is wired, its excitability.
Precisely. It provides a powerful biological model for migraine susceptibility in general, a genetically determined tendency for brain networks to be, well, more easily activated, to be tipped over the edge more easily.
And there are other rare types, too.
Yeah, another one is migraine with brainstem aura. This used to be called basilar-type migraine. It involves aura symptoms that clearly point to the brainstem, things like slurred speech, vertigo, tinnitus, double vision, maybe some ataxia or unsteadiness. But importantly, no motor weakness. That lack of weakness is key to distinguishing it. And the name change itself, from basilar to brainstem aura, reflects that shift in understanding away from blood vessels and towards the neurological origin.
And one more.
And finally, retinal migraine, very rare. It involves repeated attacks of fully reversible visual phenomena like flashing lights, blind spots, even temporary blindness, but occurring in just one eye. And that's followed by a typical migraine headache.
Okay, let's unpack this huge shift in thinking about where migraine actually comes from. For a long time, the main idea was it was all about blood vessels, right? The vascular theory. What was that all about?
Yeah, for much of the 20th century, the dominant idea was Harold G. Wolff's vascular theory. Basically, it proposed that the aura phase was caused by blood vessels inside the skull constricting narrowing, which supposedly led to a temporary lack of blood flow, maybe some ischemia.
Okay, vasoconstriction causing aura.
And then the headache itself was thought to be caused by a painful rebound vasodilation, where blood vessels outside the skull expanded too much. It kind of seemed illogical at the time. Observations like, pressing on scalp arteries, sometimes reducing pain, or the fact that drugs that constrict blood vessels like ergotamine worked those seemed to support it.
So if it seemed to make sense, why did that theory eventually, crumble? What didn't add up?
Well, a few things. For one, it just couldn't explain all the non-headache symptoms we talked about, especially that complex prodrome phase that can start days before any pain.
Right, the yawning, the mood changes.
Exactly. None of that fit the vascular model. But more importantly, when better neuroimaging came along, the studies just didn't consistently show that proposed vasoconstriction during aura. Sometimes they didn't see it at all. And sometimes vasodilation was actually seen after the pain had already started.
Ah, so the timing was off, suggesting the blood vessel changes were a result, not the cause.
Precisely. It suggested they were a consequence, not the primary driver.
And that's what really paved the way for the modern neurovascular model we have today. What's the fundamental difference in how we see it now?
Yes. This model is a complete paradigm shift. It basically says migraine is a primary neurological disorder. It originates in the brain itself. The brain, with its inherent excitability and maybe altered sensory processing, that's the initiator.
So the brain starts it.
The neuronal events are the primary drivers, yes. And they then trigger secondary changes in the blood vessels. So the vascular changes are real, they happen, but they're a consequence of the neurological attack, not its root cause. It puts the brain, correctly, at the very origin of the whole cascade.
A brain issue at its core. And it sounds like genetics play a really significant role in making someone susceptible. Almost like having a biological blueprint for migraine.
They absolutely do. Migraine is fundamentally a genetic disorder. Heritability estimates are pretty high, somewhere between 50% and 60%.
So if your parent has migraine,
your risk goes up significantly. Yeah, if you have a first-degree relative, a parent, sibling, child with migraine, your risk is substantially increased, maybe 50% to 75% higher, depending on the study.
is it just one migraine gene?
Usually not, for the common types anyway. It's typically polygenic. That means multiple genes are involved, each contributing a small amount to the overall risk. These big genetic studies, genome-wide association studies, or GWS, they've identified over 100 different spots in our DNA, genetic loci, linked to common forms of migraine. What's truly fascinating here, though, is how studying those rare forms, like familial hemiplegic migraine, gives us such clear clues about the genetics of all migraine.
Right, the ion channel mutations.
Exactly. As we mentioned, specific mutations in single genes controlling those ion channels, the gates for electrical signals in neurons make the cells hyperexcitable, too easily triggered. This provides such a powerful biological model for migraine susceptibility in general, a genetically determined tendency for certain brain networks to just be, wired a bit more sensitively, closer to their firing threshold.
And that perfectly sets up the idea of triggers, doesn't it? If your brain is already closer to that threshold genetically.
That trigger just gives it that final push. Exactly.
Pushes it over the edge.
Precisely. Triggers are factors that challenge the brain's ability to maintain balance, its homeostasis, but specifically in these genetically predisposed individuals. They're highly personal. What triggers one person might not affect another. But common ones include stress, a big one, sleep disturbances, either too little or too much.
Hormonal changes.
Definitely. Hormonal fluctuations, especially changes in estrogen for women, are major triggers. Also, strong sensory stimuli, bright flashing lights, loud noises, strong smells. Dietary factors like skipping meals, dehydration, alcohol, certain foods for some people, even changes in the weather, barometric pressure shifts.
So it's not a simple cause and effect. Your genes set the stage.
And the trigger provides the nudge, the push that initiates the attack cascade in that susceptible brain.
Okay, here's where it gets really interesting. Let's dig into the actual mechanisms, what's physically happening in the brain and nervous system during an attack. You mentioned a tripartite model. starting with something called Cortical Spreading Depression, or CSD.
Yes, CSD. This is considered the primary neurophysiological event that actually underlies the migraine aura.
The aura specifically, okay.
Yeah. Imagine this intense but slow-moving wave of electrical disturbance sweeping across the surface of the brain, the cortex. It moves really slowly, about 2 to 6 millimeters per minute, like a ripple spreading in a pond.
A slow ripple.
Very slow. It's a wave of intense neuronal and glial depolarization, basically, a massive burst of electrical activity. But it's immediately followed by a prolonged period where the neurons in its wake become suppressed, quiet.
And that slow movement explains the aura symptoms.
Directly. As this wave marches across, say, the visual cortex at that slow pace, it directly correlates with what the patient experiences, like a visual aura, maybe shimmering lights, that seems to expand or move across their field of vision over several minutes.
So it's not random firing, it's a specific propagating wave, almost like a contained short circuit.
That's a pretty good analogy, yeah. And at the cellular level, CSD involves this massive temporary disruption of the normal balance of ions, chemicals like potassium rush out of neurons, while sodium and calcium rush in. And this isn't just a harmless electrical event. CSD itself is a key trigger for the headache phase that follows.
How does it trigger the headache?
As the CSD wave passes, it causes the release of various inflammatory and signaling molecules, things like potassium ions, ATP, glutamate, and importantly, nitric oxide. These substances can then diffuse down to the meninges, those sensitive membranes surrounding the brain, and they activate the pain-sensing nerve fibers located there.
Ah, okay. And those pain-sensing fibers, that leads us to the next part of the model, the trigeminovascular system, or TVS. This sounds like where the actual pain comes from.
It is. The intense headache pain of migraine is generated through the activation of this trigeminovascular system. It's essentially a network. It involves sensory nerve fibers, primarily from a large nerve bundle called the trigeminal ganglion, which sits outside the brain. These fibers extend inwards and richly innervate the pain-sensitive structures within the head, especially the blood vessels of the dura mater and pia mater parts of those meninges we just mentioned.
So nerves wrapped around blood vessels in the brain's lining.
Exactly. And when these nerves, these paravascular nerves, get activated maybe by those chemical signals released from the CSD or by other stimuli, they release their own set of potent signaling molecules called vasoactive neuropeptides, things like substance P and, critically, CGRP.
CGRP. Okay, there it is again. Calcitonin Gene-Related Peptide. That name comes up constantly with migraine now. Why is it considered so absolutely central?
For very, very good reasons. Its role is pretty much undisputed now. First, we know CGRP levels are elevated in the blood draining from the head, specifically the jugular vein, during a migraine attack. And crucially, those levels return to normal after the attack is successfully treated.
Okay, so it correlates with the attack.
Strongly. What's more, if you give an intravenous infusion of CGRP to someone who gets migraines, it will reliably trigger a migraine-like headache in many of them. But it doesn't do that in people who don't have migraine.
Wow, that's pretty direct evidence.
It is. And perhaps the most compelling evidence is that the new therapies specifically designed to block the CGRP pathway, either blocking the molecule itself or its receptor, are highly effective for both treating acute attacks and preventing them.
So what does CGRP actually do in this system?
Well, it's a potent vasodilator, meaning it widens blood vessels. But perhaps more importantly for the pain experience, CGRP acts to sensitize the trigeminal nerve fibers themselves.
Sensitize them, meaning they become more sensitive to pain signals.
Exactly. This sensitization means that normally non-painful stimuli, like the simple pulsation of blood flowing through a meningeal artery, are now perceived as painful. That phenomenon is called allodynia, where even light touch or normal sensations can hurt.
Which explains why the headache often feels throbbing and why movement makes it worse.
Precisely. The throbbing is likely the brain perceiving those sensitized nerve endings firing with every pulse of blood, and movement increases intracranial pressure slightly, further irritating those sensitized nerves. CGRP also makes painful stimuli feel even more intense, which is hyperalgesia. It basically turns up the volume on the pain signaling system within the meninges.
And this activation and sensitization process, it involves inflammation.
Yes, the release of CGRP and other neuropeptides initiates what's called sterile neurogenic inflammation. It's sterile because there's no infection, but neurogenic because it's triggered by the nerves themselves. This causes local vasodilation and also makes the blood vessels leaky, allowing plasma fluid and proteins to seep out into the surrounding tissue. This inflammatory soup further irritates those meningeal pain receptors, creating this vicious, self-sustaining pain cycle.
And where do the pain signals go from there?
Those signals travel along the trigeminal nerve fibers back to a key relay station in the brainstem called the trigeminal nucleus caudalis, or TNC. The TNC is the primary processing center for all pain signals from the head and face. From the TNC, the signals are relayed upwards to higher brain centers, like the thalamus and the somatosensory cortex, where the pain is consciously perceived and interpreted. And if we connect this to the bigger picture, looking beyond just the immediate pain pathways, recent research has really shone a light on something called the glymphatic system.
Lymphatic system. Okay, what's that?
It's essentially the brain's unique waste clearance pathway. It's most active during sleep, and it works by flushing cerebrospinal fluid along the outside of blood vessels to wash away metabolic byproducts, cellular debris, misfolded proteins. Basically the brain's garbage removal service.
So like a literal brainwash happening while we sleep. That's fascinating. And how does that tie into migraine?
Exactly. And remarkably, preclinical research, mostly in animal models so far, but still compelling, has shown that just a single wave of that cortical spreading depression, the CSD event underlying aura, induces a profound constriction, a narrowing of the spaces around the blood vessels where this glymphatic fluid flows. It basically clamps down on the brain's drainage pipes during or after the CSD event.
Which would impair the cleaning process.
Significantly, it impairs glymphatic flow, effectively clogging the system right when the brain needs it most, after all the metabolic stress of the CSD and the subsequent inflammation.
That offers a really compelling potential explanation for the postdrome, doesn't it? That migraine hangover phase.
It really does. Think about it. The intense activity of CSD, the neurogenic inflammation that all generates a lot of metabolic waste and inflammatory molecules, if the brain's cleanup system is then impaired by the very event that created the best.
The junk just hangs around longer.
Plausibly, yes. It stands to reason these substances would linger. And this failure of efficient clearance could very well account for those lingering postdrome symptoms, the profound fatigue, the brain fog, the general feeling of malaise. It really underscores why sleep, when glymphatic function is maximal, is so crucial for recovery after an attack.
It's amazing how this deeper understanding of the why CSD, TVS, CGRP, even glymphatic has directly led to completely new ways to manage migraine. Let's shift gears and talk about those modern treatment strategies. Starting with acute treatment, stopping an attack once it starts. What's the main goal there?
Yeah, the primary goal of acute or abortive treatment is pretty straightforward. Rapidly and consistently stop or at least significantly reduce the pain and the associated symptoms like nausea and sensitivity, and crucially, restore the person's ability to function as quickly as possible.
And timing is key, right?
Timing is everything. It's most effective when taken at the very first sign of the attack. Ideally during that prodrome phase we talked about, or right at the onset of the headache pain before it really ramps up and becomes entrenched.
So what are the main types of medications used for this?
Well, for milder to moderate attacks, simple analgesics like acetaminophen and especially NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, diclofenac can be quite effective. They're often the first thing people try.
Standard over-the-counter stuff, often.
Exactly. But for moderate to severe attacks, or if those NSAIDs just aren't cutting it, then we move to migraine-specific medications.
And the first big class of those, developed specifically for migraine, were the triptans. They were a huge deal when they came out, weren't they?
Oh, absolutely revolutionary. Introduced back in the 1990s, triptans like sumatriptan, rizatriptan, and others work by targeting specific serotonin receptors, mainly the 5-HT1B and 1D receptors. This action does two main things. It constricts those dilated cranial blood vessels, which was thought to be the main effect initially, and maybe more importantly, it inhibits the release of CGRP from those trigeminal nerve endings.
And they work well for a lot of people.
Highly effective. They provide significant relief for maybe 70–80% of patients. Plus, they come in lots of different formulations. Standard pills, dissolving tablets, nasal sprays, injections, which is really helpful for people who have severe nausea and vomiting and can't keep a pill down.
But they have limitations, particularly around blood vessels.
That's the main drawback, yes. Because they cause vasoconstriction, they are contraindicated, meaning they shouldn't be used in patients with known cardiovascular disease like coronary artery disease, a history of stroke or TIA, peripheral vascular disease, or uncontrolled high blood pressure. That safety concern limits their use in a significant number of patients.
Okay, so if triptans are out because of heart issues or someone just doesn't respond well to them, what are the newer, more targeted options that have emerged recently?
Right. This is where the really exciting developments have happened in the last, say, 5 to 10 years. We now have 2 newer classes, gepants and didynes.
Gepants and didynes.
Let's start with gepants. These are small molecule CGRP receptor antagonists. So drugs like ubrogepant, rimogepant, zavegepant. The key insight here is they work by directly blocking the CGRP receptor, stopping CGRP from docking and delivering its pain signal. They prevent the downstream effects like vasodilation and sensitization without causing vasoconstriction themselves.
No vasoconstriction. That's the game changer.
That is the absolute game changer. It makes them a safe and effective acute treatment option for patients with cardiovascular risk factors who couldn't take triptans. Ravigepant is particularly interesting because it's approved for both acute treatment and for prevention.
Okay, and what about the didynes?
The main one here is lasmiditan. Didynes are different again. They selectively target a different serotonin receptor, the 5-HT1F receptor, which is found primarily on the trigeminal neurons themselves, not on blood vessel walls.
So again, no vasoconstriction.
Exactly. Activating this receptor inhibits the firing of those trigeminal nerves and reduces CGRP release, but without constricting blood vessels. So like gepants, lasmiditan is another valuable option for patients with cardiovascular concerns.
Any downsides to dipinans?
The main consideration is that they can cause central nervous system side effects in some people, particularly dizziness and somnolence, feeling sleepy. Because of that, patients are advised not to drive or operate heavy machinery for at least 8 hours after taking a dose.
Good to know. Okay, so that covers stopping an attack. But for people having frequent attacks, the bigger goal is often prevention, right? Stopping them before they even start. What's the aim of preventive therapy?
The goals of preventive treatment are really multifaceted. It's about reducing the frequency, the severity, and the duration of migraine attacks. It's also about improving how well the acute treatments work when an attack does break through. And ultimately, the main goal is to decrease the overall disability and improve the person's quality of life.
Who typically needs preventive treatment?
It's generally indicated for people who have frequent attacks, say 4 or more migraine days per month, or attacks that are particularly severe or long-lasting, even if less frequent, especially if they cause significant disruption. Also, if acute medications aren't working well, are overused, or have problematic side effects. Estimates suggest about 40% of people with migraine could benefit from prevention, but historically, it's been significantly underutilized.
Yeah, and for years, it seemed like the preventive options were mainly drugs borrowed from other conditions.
Yeah.
And they often came with a hefty side effect burden.
They were, and they definitely still have a role. We call them the traditional oral medications, or sometimes non-specific preventives. This group includes certain antihypertensives like beta blockers, propranolol, metoprolol, and an ARB called candesartan. Also some anti-epileptic drugs like topiramate and valproic sodium. And certain antidepressants, particularly older tricyclic antidepressants like amitriptyline, or newer ones like venlafaxine.
But the side effects could be tough.
They could be, yes. While these drugs can be effective for some, their use has often been limited by that lack of specificity. They weren't designed for migraine, and the side effects can be burdensome. Topiramate is famous for causing cognitive issues, that brain fog and tingling sensations. Dalprox can cause weight gain, hair loss, and is a definite no-no in pregnancy due to birth defects. The antidepressants often cause sedation, dry mouth, weight gain. These side effects, unfortunately, often lead to poor adherence. People just stop taking them.
Which really highlights why the arrival of targeted preventive therapies, specifically designed for migraine, has been such a revolution in the last decade or so.
Absolutely. This is what we call the modern era of prevention. It started becoming more targeted with onabotulinum toxin A, or Botox.
Botox for migraine.
Yes, but importantly, it's approved only for the prevention of chronic migraine, not episodic. It involves a series of 31 small injections into specific muscles in the head and neck repeated every 12 weeks. The exact mechanism isn't fully understood, but it's thought to inhibit the release of CGRP and other inflammatory neurotransmitters from nerve endings in those areas.
Okay, Botox for chronic. And then came the really big breakthrough, targeting CGRP directly for prevention.
Exactly. The true revolution arrived with the CGRP-targeting monoclonal antibodies, or MABs. These are large biologic molecules, proteins designed in the lab. There are currently 4 available, Erinumab works slightly differently by blocking the CGRP receptor. The other three, furmanizumab, galcanezumab, and eptinezumab, work by binding directly to the CGRP ligand itself, basically neutralizing it before it can reach the receptor.
And how are they taken?
They're typically administered via a simple subcutaneous injection like an insulin shot, either once a month or sometimes once every 3 months, depending on the specific drug. Eptinezumab is given as an intravenous infusion every 3 months.
And the results?
They've shown really robust efficacy in clinical trials, significantly reducing the number of monthly migraine days for many patients with both episodic and chronic migraine. But perhaps just as importantly, they have demonstrated an exceptional tolerability profile. The side effects are generally very mild, most commonly just some reaction at the injection site. Erinumab has been associated with constipation in some people, but overall, compared to the older oral preventives, the tolerability is vastly better.
That sounds like a huge step forward. And now we also have oral options targeting CGRP for prevention too, the preventive gepants.
Yes, that's the latest major advance. These are small molecule CGRP antagonists, similar to the acute gepants, but specifically developed and approved for prevention. Atogepant is a daily oral tablet. And rimegepant, which we mentioned for acute treatment, is also approved for prevention when taken every other day as an oral dissolving tablet.
So oral convenience with that targeted CGRP mechanism and good tolerability profile.
Exactly. It offers another great option, particularly for patients who might prefer an oral medication over an injection.
So with all these incredible advances, the MABs, the preventive jabrants, what does this all mean for patients and doctors making treatment decisions right now? Especially considering those landmark new guidelines from the American Headache Society in 2024. This feels like a really fundamental shift.
It truly is. It's a watershed moment, really. In 2024, the AHS published updated consensus recommendations for migraine prevention. And based on the comprehensive data we now have on efficacy, safety, and tolerability, they made a landmark move.
Which was?
They now recommend that CGRP-targeting therapies, both the monoclonal antibodies and the preventive gepants, should be considered first-line option for migraine prevention, right alongside those traditional oral treatments like beta blockers or topiramate.
First line. So potentially starting with these newer targeted therapies right away, not necessarily having to try and fail the older ones first?
Exactly. This is a huge shift away from the fail first or step therapy approach that many insurance companies have historically mandated, where patients often had to cycle through multiple older drugs, potentially suffering side effects, before being allowed access to the newer agents.
That sounds incredibly patient-centric.
Yeah.
What was the reasoning behind this major change?
The rationale is crystal clear. The robust efficacy data combined with the vastly superior safety and tolerability profiles of the CGRP-targeted drugs compared to many of the older options. This change really represents a philosophical evolution in migraine management. It moves away from a primarily cost-driven, stepwise protocol towards a truly patient-centric model based on shared decision-making between the clinician and the patient.
So tailoring the first choice to the individual.
Precisely. It empowers clinicians and patients to select the most appropriate initial preventive therapy based on the individual's specific migraine characteristics, their other medical conditions, comorbidities, their lifestyle preferences, and treatment goals. The ultimate insight here is that getting patients on the right therapy for them sooner can lead to faster, more effective disease control, potentially preventing that debilitating progression from episodic to chronic migraine, and ultimately reducing the overall burden on their lives much more quickly and effectively.
That's fantastic progress on the medication front. But it's clear that managing migraine effectively often involves more than just pills or injections. What about non-pharmacological and integrative approaches? How important are they?
Oh, they're absolutely vital components of a comprehensive management plan. They really empower patients to take an active role in their care, can improve their resilience to triggers, and reduce reliance on medication. They can be used as standalone strategies for some, or more often, as crucial adjunctive therapies alongside medication.
What are some of the cornerstones here? Lifestyle seems key.
Lifestyle modifications are foundational. Things like maintaining consistent sleep schedules, going to bed, and waking up around the same time every day. Regular meal timing, avoiding skipped meals, ensuring adequate hydration, and engaging in regular, moderate aerobic exercise, although it's important to start slowly and warm up well, as sudden intense exertion can sometimes be a trigger itself.
And tracking things helps.
Definitely. Using a headache diary is a crucial tool here. It helps patients and their doctors identify patterns, potential triggers, and track how what treatments are working. It really informs personalized management.
What about supplements or vitamins? Any evidence there?
Yes, for nutraceuticals, there's actually reasonably strong evidence supporting a few for migraine prevention. The best evidence is for high-dose riboflavin, that's vitamin B2, coenzyme Q10, and magnesium. Petacites or butterbur also has some evidence but carries concerns about liver toxicity, so it needs careful consideration and monitoring. Feverfew has more mixed results.
And then there are therapies that focus on behavior and the mind-body connection.
Exactly. Behavioral and physical therapies can be very effective. Cognitive behavioral therapy, or CBT, helps patients identify and change negative thought patterns and behaviors related to their pain and disability, improving coping skills. Biofeedback is fascinating. It uses sensors to give patients real-time information about physiological processes like muscle tension, heart rate, or skin temperature, and then teaches them techniques to gain voluntary control over these processes, which can help manage stress responses.
Relaxation techniques, too.
Yes, things like mindfulness meditation, progressive muscle relaxation, guided imagery, and paced breathing exercises are excellent tools for managing stress, which is such a common trigger. And acupuncture also has some supportive evidence and may help reduce headache pain and frequency for certain individuals.
Beyond pills, lifestyle, and behavioral changes, there's also this really cutting-edge area of neuromodulation. These device-based therapies sound quite different.
They are. Neuromodulation uses devices to deliver targeted electrical or magnetic stimulation to specific nerves or brain regions thought to be involved in migraine pathophysiology. They represent a really valuable non-pharmacological approach, especially for patients who maybe don't respond well to medications, can't tolerate the side effects, or have reasons they need to avoid medications, like during pregnancy.
What are some examples of these devices?
One is external trigeminal nerve stimulation, or ETNS. The most well-known device is Safely. It's a small device worn like a headband with an electrode placed on the forehead. It delivers gentle electrical pulses to stimulate branches of the trigeminal nerve. It's actually approved for both acute treatment during an attack and for daily use as a preventive therapy.
Interesting. And you mentioned magnetic stimulation as well.
Yes, that's single-pulse transcranial magnetic stimulation, or STMS. The device, Sevi Spring TMS, is handheld. You place it against the back of your head and it delivers a brief, single magnetic pulse. The idea is that this magnetic pulse can disrupt that wave of cortical spreading depression, the CSD, that underlies aura, so it might be particularly relevant for people with aura. It's approved for acute treatment of migraine.
Oh, one more type.
The third main type is non-invasive vagus nerve stimulation, or NVNS. The device here is GammaCore. It's handheld and applied to the side of the neck over the vagus nerve. Stimulating the vagus nerve is thought to modulate pain processing pathways in the brainstem and reduce neuroinflammation. It's FDA approved for the acute treatment of migraine and also for episodic cluster headache.
It's really clear that migraine takes a huge toll on individuals.
Yeah.
But zooming out, the broader burden on society as a whole is truly staggering, isn't it? How do we even start to quantify that socioeconomic impact?
It's immense. As we touched on earlier, migraine is consistently ranked among the most common and disabling diseases globally, third most prevalent disorder worldwide. And it's the single leading cause of years lived with disability YLDs for people in their prime working and family years, basically ages 15 to 49.
Leading cause of disability in that age group. It's huge.
It really is. In the U.S. alone, estimates suggest migraine affects 1 in 4 households. And this translates into absolutely colossal economic costs.
And those costs break down into different types, right?
Yeah.
Direct medical costs and then the indirect costs from lost productivity.
Exactly. The direct costs are the tangible healthcare expenses, medications, doctor visits, emergency room trips, hospital stays, diagnostic tests like MRIs. These are estimated to be somewhere between $11 billion and $17 billion annually just in the U.S. On average, individuals with migraine incur healthcare costs that are about twice as high as people without migraine.
Twice as high, wow.
But then you have the indirect costs, which stem from lost economic productivity. And these are often equal to or potentially even greater than the direct costs, another estimated $11 billion or more per year in the U.S.
And that includes missing work, but also working while impaired.
Precisely. Indirect costs cover absenteeism days completely missed from work or school due to migraine. But a huge, often hitting component is presenteeism. That's when someone is physically at work or school, but they're symptomatic, maybe in pain, nauseous, struggling with brain fog, and their effectiveness and productivity are significantly reduced.
And presenteeism costs more.
Estimates suggest the economic impact of presenteeism might be double the cost of outright absenteeism. It's a massive drain on productivity that's frequently underestimated by employers and the individuals themselves. So when you add it all up, the total U.S. economic burden of migraine is estimated somewhere in the vast range of $22 billion to perhaps as high as $78 billion annually. It's astronomical.
And despite that staggering cost, migraine research is underfunded.
Shockingly so. Despite this profound personal and societal impact, migraine remains notoriously underfunded and relatively neglected in terms of public research dollars compared to other major neurological diseases with similar or even lower prevalence and disability burdens. That's a major ongoing challenge and a source of frustration in the field.
Beyond the billions of dollars, there's the deeply personal toll. Those economic figures just can't capture the crushing impact migraine has on a person's actual quality of life, can they?
Not even close. The health-related quality of life, or HRQOL for people living with frequent migraine, is severely compromised. Studies consistently show it's comparable to, or in some domains, even worse than, the impacts seen in other major chronic conditions like diabetes, arthritis, or even congestive heart failure.
That puts it in perspective.
It really does. During attacks, individuals are often completely disabled, forced to retreat into isolation, usually a dark, quiet room. This profoundly disrupts their ability to work or pursue education, leading to missed days, impaired performance, sometimes even career limitations, or choosing lower-paying jobs with more flexibility. And it heavily impacts family life and social interactions, canceled plans, missed holidays and events, feeling like a burden, dealing with misunderstanding from others who think it's just a headache.
And you mentioned this concept of the interictal burden, the impact even on the days between attacks, like the fear itself takes a toll.
Exactly that. The constant fear, anxiety, and anticipation of the next attack can hang over a person even on their good days. This often leads people to proactively limit their activities, maybe avoiding social engagements, travel, or other things they might enjoy just in case it triggers an attack. It essentially shrinks their world, even when they're not actively having a headache.
And this burden is often amplified by other health conditions that tend to go along with migraine, comorbidities.
Yes, that's a huge factor. Migraine frequently co-occurs with other significant medical and psychiatric conditions, which complicates treatment and further worsens quality of life. The most common comorbidities are depression and anxiety. The relationship is often bidirectional, meaning migraine can worsen mood disorders, and mood disorders can worsen migraine.
What else?
There's also an increased risk of epilepsy, and particularly for migraine with aura, an increased risk of stroke. Other common comorbidities include irritable bowel syndrome, IBS, asthma, fibromyalgia, and other chronic pain conditions. Managing migraine effectively often means addressing these co-occurring conditions as well.
And we touched on this earlier, but this often intersects with socioeconomic status, potentially creating a really difficult downward spiral for people.
It absolutely does. Research shows that lower socioeconomic status, SES, is independently associated with both a higher prevalence and increased frequency of migraine attacks. And it can create a truly vicious cycle.
Oh, so?
Well, lower SES might lead to factors that can worsen migraine, like increased stress, potentially poorer nutrition, limited access to preventative care or effective treatments due to cost or insurance issues. Then, the worsening migraine leads to greater disability, more missed work or school days, reduced earning potential, which in turn reinforces or worsens the low socioeconomic status. When you layer on a comorbidity like depression, which is also linked to SES, it just magnifies the disability and makes it even harder to break the cycle. It really highlights why addressing migraine effectively is such a critical issue of public health and health equity.
So to truly understand that full impact, disability, the quality of life issues, and to really gauge the success of these newer treatments, we absolutely need to hear directly from the patients themselves. That's where patient-reported outcomes, or PROs, become so incredibly important, right?
Exactly. They are crucial. Traditional clinical trial endpoints, like simply counting the reduction in the number of monthly migraine days, while useful, they just don't capture the full picture of how migraine impacts a person's ability to feel and function in their everyday life. PROMs are standardized questionnaires designed to gather this information directly from the patient's perspective. They provide a more holistic, human measure of treatment success.
What are some of the key PROMs that are commonly used in migraine research and clinical practice?
There are several validated tools. The Migraine Disability Assessment, or MIDAS questionnaire, is widely used. It quantifies lost time, days missed from work, school, or household activities, and days where productivity was significantly reduced over the past 3 months due to migraine.
Okay, so it measures disability.
Yes. Then there's the Headache Impact Test, or HLT6. This is a shorter questionnaire that measures the overall impact of headache across several domains, including pain severity, social functioning, cognitive functioning, fatigue, and psychological distress. It gives a good snapshot of the overall burden.
And quality of life specifically.
For that, we often use the Migraine-Specific Quality of Life Questionnaire, or MSQ. This one dives deeper into how migraine specifically affects different aspects of life, like role function, ability to perform daily tasks, activities, relationships, and emotional well-being.
And it sounds like these prompts were absolutely essential in demonstrating the real-world value of the newer therapies, like the CGRP mAbs, beyond just headache frequency reduction.
They were incredibly important, yes. The clinical trials for the CGRP antibodies, for instance, routinely included prompts like MIDAS, HAT6, and MSQ. And the results consistently showed that these effective treatments didn't just reduce the number of headache days. They also led to statistically significant and, more importantly, clinically meaningful improvements in patient-reported quality of life, reductions in headache-related impact scores, and decreases in disability levels.
So they really showed the treatments were making a difference in people's lives.
Exactly. They showed these therapies were literally giving patients days of their lives back, allowing them to re-engage with work, family, and social activities. PROMs ensure that the ultimate goal of treatment, which is improving the patient's overall well-being and ability to function, is actually being measured and achieved. They capture the patient's voice in assessing treatment success.
We have certainly covered an incredible amount of ground today, from really defining what migraine is and isn't, to unpacking its complex neurobiology, and then exploring this whole revolution in modern management strategies. It genuinely feels like the understanding and treatment of migraine have undergone a profound transformation.
They absolutely have. It's been a remarkable journey, really, going from viewing migraine as this poorly understood vascular headache to recognizing it as a well-defined complex neurobiological disorder with specific targetable mechanisms. It truly represents a triumph of translational medicine, where basic science discoveries directly led to life-changing therapies.
Yeah, that deeper understanding of the pathophysiology, CSD, the trigeminovascular system, and especially nailing down the role of that master molecule, CGRP, that directly paved the way for this therapeutic revolution we've discussed.
Couldn't agree more.
And that 2024 AHS guideline shift, formally recognizing CGRP therapies as first-line options, really solidifies that progress, doesn't it? Fundamentally changing the outlook, the prognosis for millions by potentially getting them access to more effective and tolerable treatments much faster.
It's a paradigm shift with real-world implications for patient care, absolutely.
But despite all this incredible progress, challenges obviously still remain in the world of migraine. What are some of the persistent unmet needs?
Well, significant unmet needs definitely persist. Even with the highly effective CGRP-targeted therapies, roughly 1/3 of patients, unfortunately, don't respond adequately. So managing refractory chronic migraine, the really difficult-to-treat cases, remains a formidable clinical challenge that requires ongoing research into new mechanisms and treatment targets.
And access is still an issue.
Access is a huge issue. While these novel therapies offer immense hope, their high cost often leads to restrictive insurance policies, prior authorization hurdles, and high patient copays. This creates significant barriers to access, particularly for patients with lower incomes or less comprehensive insurance, and it perpetuates health disparities. Ensuring equitable access to these transformative therapies is a major ongoing challenge.
And with any powerful new class of drugs, especially ones that target a molecule like CGRP, which has roles throughout the body, there's always that valid question about long-term safety, isn't there?
That's a critical and entirely valid concern. Given CGRP's known physiological roles, for instance, in cardiovascular homeostasis and blood pressure regulation, people really asked about potential long-term effects of blocking it systemically for years or decades.
So what does the data show so far?
Thankfully, the safety data we have accumulated thus far from the large initial clinical trials, the open-label extension studies where patients stayed on the drugs for years, and now extensive post-marketing surveillance covering millions of patients has been overwhelmingly reassuring.
That's good to hear.
Yes, these studies have not revealed any significant signals of major cardiovascular or cerebrovascular safety issues. As we discussed, the most common side effects have generally been mild and manageable, like injection site reactions or constipation with Erinumab. However, it's crucial to maintain perspective. These are still relatively new therapies in the grand scheme of things. Continued vigilance, ongoing collection of real-world safety data, and long-term post-market surveillance are absolutely essential as these treatments are used by an increasingly diverse population of millions of patients over the course of their lives. We need to remain watchful.
That makes sense. Continuous monitoring is key.
So reflecting on everything we've discussed today, the phases, the underlying biology, the new treatments, the burden, this raises an important question, maybe something for you, the listener, to think about. What stands out to YU about how understanding all these facets, the prodrome, the CSD, the postdrome, the role of CGRP, could potentially change how people who live with migraine view their own experiences, and perhaps just as importantly, how society understands and supports them?
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.